السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته.
ما
تمام يا
تحبوا
دكتور.
نبدأ قولوا لي.
نبدأ يا دكتور. تمام.
Okay, توكلنا على الله. بسم الله الرحمن الرحيم. Today we have an extremely important topic, and it's actually a challenging and tough topic. But every neonatologist and any pediatrician who is taking care of newborn babies should be aware of these information. It's fluid and electrolytes management, and management of fluid and electrolyte disorders in the newborn baby, term and preterm. And before we start, as we used to do, I will go from backwards forwards. I will give you some brain stimulation, and then we'll start presentation. I will give you some MCQs and some cases, and then we'll be back to the presentation. Okay. So this is a 6-hour-old preterm neonate. Birth weight is 640 grams. Gestational age is about 24 weeks. Is under radiant warmer. Ambient humidity is 80%. The infant is on mechanical ventilation requiring oxygen 42%. Has an energy tube for suction. No anomalies, no syndromes. And we are estimating this infant fluid and electrolyte needs. This is a straightforward question. Of the following, the major consideration in fluid electrolyte management for this infant is, when you calculate the fluids, what is the most important factor you will take into consideration as number one? But the other items are important, but what is number one? Gastric drainage, water loss, insensible water loss, stool water loss, sweat water loss, or urinary water loss. Think about it. And number two, a preterm neonate loses 10% to 20% of body weight during the first week after birth. This weight loss is considered physiologic. Of the following, the physiologic weight loss in the preterm is best attributed to postnatal decrease. And what is the compartment that decreases in the preterm baby? Causes causing weight loss? Is it the body fat? Is it caloric intake? Is it interstitial fluid volume? Is it intracellular fluid or the plasma volume? What do you think? The compartment that adds more to the weight loss in the first few days of life. 25 to 50% of neonates who weigh less than 1,000 grams at birth or whose gestational age is less than 28 weeks develop hyperkalemia in the first 24 to 72 hours after birth. Hyperkalemia in the preterm baby. Of the following, the most likely cause of hyperkalemia in such preterm neonate is it high exogenous potassium intake? You give the baby too much potassium. High proximal tubular reabsorption of potassium. Kidney absorbs more potassium more efficient than other ages. Low distal tubular excretion of potassium because of immaturity. Low glomerular filtration rate of glomerular filtration of potassium, selective. Shift of potassium from intracellular to extracellular fluid compartment. Okay, number 4. An infant born at 24 weeks, birth weight is 640 grams, receiving CPAP, enteral feeds by gavage, donor breast milk fortified with human milk fortifier, liquid protein, 26 kilocalorie per ounce for a total of 130 kilocal per kilogram per day. His growth velocity is 9 gram per kilogram. 9 gram per kilogram per day. And a blood chemistry panel is obtained showing sodium 125, potassium 3.2, chloride 100, bicarb 22, blood urea nitrogen 12, creatinine 0.6, calcium 9, phosphorus 4, total protein 6, albumin 3.2. The cause of this low growth velocity in this infant is decrease in aldosterone concentration in this baby, free water loss, inhibition of sodium hydrogen anti-porter, low glomerular filtration rate. Think about it. Number 5, a newborn is delivered at 23 weeks, birth weight 530 grams, has a UVC and USC, TPN started, total fluids 130 per kg per day. Of the following, the statement that best describes the rationale for avoidance of early sodium administration in this infant is why you didn't give sodium early in the first 1 or 2 days. Because of administration of sodium hinders contraction of the neonatal extracellular fluid space, or early sodium administration causes hypernatremia, or neonatal sodium stores are adequate and mirror that of the mother, or sodium resides primarily in the neonatal intracellular fluid space and is not initially required. Number 6, the value below are taken from 2 neonates admitted to the ICU, to the NICU. Baby A and baby B. Baby A is born at 28 weeks, 10 days old. Baby B is a term baby, now 2 days old. And examination findings and laboratory results for both neonates are shown. The birth weight for the 28-weeker, 1,200 gram. For the term, 2,800 gram. Current weight of age of 10 days for the preterm is 998 grams. So lost a good amount of grams. The baby B, current weight at the age of 2 days is 2,600 grams. Serum sodium, 130 milliequivalent in both. Urine output is appropriate for both 6 in the preterm and 4 milliliter per kg per hour for the term baby. So, of the following, the best explanation for the baby A's weight loss compared to baby B. So, explanation for comparing weight loss in baby A, the preterm, compared to baby B, is that aldosterone response is diminished in the preterm infant. Mineralocorticoid secretion is excessive in the preterm infant. Renin secretion is diminished, or vasopressin response is excessive. Okay, so which of which? Then number 7, 800 grammer, 835 gram neonate, 25 weeks is admitted, mechanical ventilation for the RDS, UVC and UVC inserted, and given sodium acetate 0.45 solution through the UAC and 0.8 milliliter per hour. And nutrition is initiated, and the fluid intake goal is 120 cc per kg per day. On the second day after birth, 3 milliequivalent per kg per day of sodium is added to the TPN, and trophic enteral feedings are started with non-fortified pasteurized human milk from the human milk bank. The UAC is removed at the day of 5. Changes in the infant weight intake and output and serum sodium values during the first 6 days after birth are shown. So if we go by days, we start day 1, day 2, 3, 4, 5, whatever. The weight, birth weight was 835, and this is the weight in the second day. This is the weight in the third day. Minimal loss, some loss, gain, weight gain at day of life 4, weight gain, weight loss at day of life 6. So this is the fluids given to the baby, and this is the total fluids given, and these are the total feeds given. This is the urine output per kg per day, which is increasing. And then serum sodium at day of life 2, 140, 149 in day 3, then started to drop in day 4, at day 5, 133, and day 6, 122. Okay? So they did random urine sodium and urine osmolality on day 6 after birth. It was 101 milliequivalent and 391 milliosmol respectively. This is the urine sodium and urine osmolality. Of the following, this neonate hyponatremia, on day of life 6 could have been best prevented by advancing enteral feedings at a faster pace. This is the rate of enteral feeds. If they went faster, they could save the baby this hyponatremia. Fortifying the enteral feedings, going up on the calories, increasing parenteral nutrition sodium content at day of life 5. So at this day of life 5, they should have went up on the sodium at this day. Or lowering the total fluid goal after day 3. Number 8, a 40-weeker, 3,640 grams, urgent C-section, non-reassuring fetal status. The newborn is limp, apneic, associated Apgar scores of 1, 3, and 6. So most probably this is a possible HIE. On admission to the NICU, the newborn is receiving mechanical ventilation, heart rate 146, blood pressure 52/41, and the mean arterial blood pressure is 44. 4 seconds capillary refill time, so the baby is still shocky. Neurologic examination finding suggestive of severe encephalopathy. This is HIE. The initial arterial blood gas findings show severe metabolic acidosis. Yes, this is HIE. Therapeutic hypothermia implemented, antibiotics and dextrose 10% given IV at a rate of 60 cc per kg per day. A 10 milliliter per kg normal saline bolus is given. Subsequent arterial gas findings are shown with an interval, as we are going to see. The newborn remains ventilated, had FiO2 of 70%, and arterial blood pressure is 48/30, and the mean is 37, still dropping. Laboratory results are shown. So the pH of the blood gas initially 6.84, after the bolus 7.15. PaCO2 40 dropped to 21. PO2 67, more or less 56, bicarb 7 and 8, basic 69 minus 27 minus 22. Lactate more than 153 in both times. Oxygenation index 18 and 15, and hematocrit 58, 55. Of the following, the best next step in the management of this infant metabolic acidosis is give a normal saline bolus again, give sodium bicarb, obtain an echo, start vasopressin infusion. Vasopressin infusion. Number 9. 19-day-old neonate born at 25 weeks gestation receives a CPAP for RDS. For the first 6 days after birth, unit has been tolerating enteral feedings. Maternal breast milk 160 cc per kg, caloric density 128, protein content 4.3. However, the neonate had persistent tachypnea and inconsistent weight gain over the past 4 days. Labs. Hematocrit 42, sodium 136, borderline normal. Potassium 4.7, chloride is okay, 106, bicarb 14, urea nitrogen, BUN 9, creatinine 0.41, glucose is 85, calcium 11. Urine sodium 55, blood gas 7.25, PaCO2 35, bicarb 15, and base excess is minus 11. This baby is having metabolic acidosis. The most likely cause of this neonate's recent suboptimal weight gain is inadequate enteral protein provision. It was given 4.3 gram per kg per day. Metabolic acidosis, negative sodium balance. Sodium is borderline normal or low normal. Negative sodium, suboptimal enteral energy provision. The calories are low. Number 10, and the last MCQ. A 1-week-old infant born at 31 weeks. Mom had polyhydramnios, this keyword, which was noted at the age of 24 weeks. Infant is SGA. Since admission into the NICU, the infant has had high urine output. There is polyuria. So polyhydramnios, SGA, polyuria. Laboratory labs are sodium 135, low, normal. Potassium is low, 2.8. Chloride is low, 94. Bicarb 34, high. Urea nitrogen is 8. Creatinine 0.6. Calcium 9.8. Magnesium 1.8, low. Or it's borderline normal. Phosphorus 5.6. And urine protein negative. Urine calcium creatinine ratio 1.2. Of the following, these infant symptoms are most likely caused by the impaired reabsorption of. And to know the answer, you should know what you are dealing with. A baby who is having polyhydramnios, history of polyhydramnios, SGA, polyuria, hypokalemia, hypochloremia, alkalosis, metabolic. So, of the following, these infant symptoms are most likely caused by the impaired reabsorption of calcium via Claudine 16 channels, calcium problem, chloride via CLC-KB channels, sodium via NKCCU2 channels, or water via whatever channel. Okay. Before starting, let me look at some of your chats, and I will not comment because we might go back again to these MCQs after we are done. I don't know. I'm sorry. I don't know what D for which, D, B, B. I don't know which questions you are talking about. So looking at the chat is useless now. So we'll start. But this was like brain stimulation. We'll be back again to the beginning. We might need another session, by the way, because this is a very lengthy topic. Slideshow from the beginning. So, review. We are going to talk about what are the objectives in tiny brief introduction, and then we have to go through physiology, which is extremely important. If you don't know physiology, you don't know pathology. And this includes fluid compartments, fluid and electrolyte homeostasis, regulatory factors affecting this homeostasis, and then we'll go to the organs dealing or affecting the homeostasis, the kidney, the lung, the skin, the GI, lymphatics, and hormones, autonomic nervous system, and capillary permeability. And because we are going to discuss a fluid and electrolytes in the newborn baby, which is either term or preterm, the preterm could be at any gestational age, starting from 22 to 37 weeks. So every and each preterm baby is at a certain stage of the physiology, the fetal physiology in utero. If you have a 25-weeker born in the NICU, this 25-weeker represents the fetus in utero, how this fetus is behaving, electrolyte and fluid-wise at this gestational age. So fetal physiology is important. And another important issue that makes the fluid and electrolytes are challenging in the newborn baby is that we are not dealing only with term and preterm babies, and the preterm babies are at different gestational ages, and every gestational age the baby has his or her own behavior, but also there is immediate neonatal changes. There is this electrolyte and fluid homeostasis is dynamic. It is not static, meaning there is some changes that occur after delivery. The fetus was totally dependent on the mother and the placenta in utero. But once the baby is delivered, whether term or preterm, will become totally independent and has to adapt to the extrauterine life, which does not happen immediately in a glance. No, it needs time. So there is immediate transitional changes in the fluid and electrolyte homeostasis that happen in the post-term days for any newborn baby, whether term or preterm. And in the preterm, it depends also on what is the gestational age. You have to be familiar with that. There is no like a single table that will give you what are the fluid and electrolyte requirements for a newborn baby. This, if you know, it's not that easy. Every and each baby has his own behavior depending on mainly on the gestational age, on the postnatal aging days, but also on other conditions like what is the pathology, what is the disease the baby is suffering from. Okay. And then we will, based on that, we'll discuss the requirements, daily requirements, and then we will mention some of the main disorders affecting fluids and affecting electrolytes, and then how we assess the baby clinically and by lab, and how can we monitor, and what labs we can do, what is the differential diagnosis for every and each problem, and how we can manage these problems, especially in certain clinical disorders. And then we go to conclusions. What are the ongoing lessons and references, MCQs? We already discussed them. And then I have 4 cases to discuss. We'll discuss them after finishing. What are the objectives of this talk? We have to understand fetal and neonatal fluid and electrolyte homeostasis. And we know now why fetal homeostasis is important, and also neonatal, whether term or preterm. And then what are the regulatory mechanisms? Because if we don't know that, we don't know physiology, we don't know pathology. Because if we what is the treatment is to turn pathology back into physiology. And what are the immediate neonatal transitional changes that occur to the term and preterm babies? What are the daily requirements for both? And what are the challenges in preterm babies compared to the term ones? And then pathological conditions affecting the fluids, the electrolytes, and how we can manage them. So, assessment of the fluid and electrolyte properly in neonate is very important, but it's difficult and challenging. Fluids mean water. Electrolytes, sodium, potassium, chloride, and bicarb. It also includes calcium and phosphorus, but if we include calcium and phosphorus, this presentation will be more and more lengthy, and we have to spend more time. So there will be another discussion about calcium and phosphorus metabolism, homeostasis, and disorders in the newborn baby in a separate presentation. But if somebody asks you, yes, calcium and phosphorus are included, but not in this presentation. And we know that why it's challenging, because it depends on the gestational age, the postnatal age in hours, and associated environmental and pathological condition. And you have, the neonatologist should have an in-depth understanding of these fluid and electrolyte homeostasis, should know physiology and pathology and pharmacology of the drugs we are going to use, especially diuretics. And this allows strategic planning for tailored treatment of each neonate. Actually, each neonate has his own personality. You have to tailor treatment for every and each newborn from the point of fluid and electrolytes. Okay, so fluid balance assessment is critical because physiologic fluid accumulation in the newborn, especially in the preterm babies, what we call fluid overload, is extremely serious. Fluid overload in preterm infants is serious, associated with high morbidities and high mortalities, as we are going to discuss. So we have to do careful evaluation of the neonate, fluid status, kidney function, underlying pathology, and other conditions. So we'll try to discuss some of the important physiologic issues, and we'll not go into the depth because each item will need one lecture. But we'll try to refer to the important points briefly. So we should know what are the fluid compartments. This is for any and every baby. What is the insensible water loss? What is the sensible water loss? So we have total body water, which is a high percentage in the newborn baby, especially in the preterm, and definitely in the fetus. And it is either intracellular or extracellular. And the extracellular is either intravascular or interstitial between the cells. And the intravascular is either in the blood vessels, plasma, or in the lymphatic vessels. So the third newborn baby has 75% of body weight as water, 40% extracellular, and 35% intracellular. And of course, if we compare this to the adult has only 60% water, 20% extracellular, 40% intracellular. So the total amount of water is higher in the newborn baby, and distribution is different. And the baby has to lose, if the baby is term, has to lose between 5 and 10% of this weight, mostly in the form of free water. This is extremely important. And this is physiologic, and you have to allow it. If you don't allow it, you are working against nature and you are overloading your baby with fluids. This is if the baby is term. If the baby is preterm, the percentages are different, as we are going to see. So fluid and electrolyte homeostasis is just a balance between intake and output. Output means losses, and mostly it is in the urine. And this is the sensible water loss, in addition to other like GI or whatever other sources of loss. But there is an insensible water loss, which is extremely important in the preterm baby, because the preterm baby has very thin, immature skin through which water is lost. It's mostly free water. So insensible water loss is this fraction that is not measured. It is mostly either evaporation through the skin, which can be as high as 2/3, or the respiratory tract and mucous membranes. It depends on gestational age, and the more the baby is preterm, the higher the insensible water loss. That's why the fluid requirements of the preterm baby are higher compared to the term baby. Okay? Because skin matures with age, so this insensible water loss decreases with gestational age, decreases with maturation. So in day 1, it's different from day 2, day 3, and if the baby is term, it's totally different from a preterm baby. The sensible water loss, we know about this. We know about the urine. We can measure it. Loss of fluids in stools, like in diarrhea, or from other GI sources, like as if you do gastric aspiration or you do decompression of the intestine in case of obstruction or necrotizing enterocolitis, or from other sources like draining CSF fluid. Okay, like if you have a hydrocephalus or other problem. This picture is extremely important. This figure is extremely important. And this is the total body weight. And this is the solid. This is the water. And this is the intracellular compartment, and this is the extracellular compartment. You see, if you look at the fetus, like 16-weeker, the baby is 10% solid, the fetus is 10% solid and 90% water. 59% is extracellular and only 31% is intracellular. And the more the fetus advances in gestational age, the more the total fluid will become less, losing more extracellular fluid, going to intracellular fluid. So if you go to a term baby, the total water is 75%, 45% is intracellular, 30% is extracellular. If you compare it to for 24-weeker, it's different. The total water is about 86%, 34% of them are intracellular, and 52% is extracellular. This is extremely important figure. So homeostasis of fluids and electrolytes is extremely important, and it is regulated mostly by the kidney, you have other contributors. And the newborn baby, especially the preterm ones, are more susceptible to derangements in the water and electrolyte homeostasis because of their relative immaturity, because they have a dynamic process of change after delivery, and because the insensible water loss is of paramount importance, especially in the preterm babies. And this changes with postnatal age. Day 1 is not like day 5 or 7. So for every and each newborn baby, there should be a phase of diuresis. It starts like day 1 to 2, stays for like 2 to 3 days, and it depends on the gestational age. The higher the lower the gestational age, the higher is the diuresis, the amount or the percentage of the diuresis. Okay, and this is physiologic. and you have to deal with that, and don't try to give like more fluids or prevent the diuresis, because this is not physiological and has, if you do fluid overload, you will do increase the pathology, the morbidity and mortality. What are the regulatory factors or organs that affect? We'll go briefly on every and each one of them. We have, this happens according to certain physical and chemical laws, like the hydrostatic pressure gradient, like the diffusion laws. And then we have organs, the kidney, the lung, skin, GI, the pituitary, suprarenal glands, arteries, veins, capillary permeability, and lymphatics. And hormones, the renin angiotensin system, aldosterone, ethereal natriuretic peptide, antidiuretic hormone, which is arginine, vasopressin, and steroids. And we have to know the rules that govern tissue fluid formation, which is summarized in two processes, filtration and reabsorption. So if we look at the capillaries, there is an arterial end, there is a venous end. We have main factors that work on the filtration at the arterial side and reabsorption at the venous side. It depends on the pressure gradient between the hydrostatic pressure and the oncotic pressure, which is the osmotic pressure of the proteins of albumin. So if we are at the arterial end, we have hydrostatic pressure is more or less around 35 millimeters of mercury, and oncotic pressure is 25. So the difference is 10 in favor of filtration. On the venous side, the opposite occurs. The difference is -7, allowing for reabsorption. And the rest is to be taken care by lymphatics. Okay? By lymphatics. About 10% of the interstitial fluid will go back through the lymphatics to the general circulation again. And also, osmosis plays a role. If you have increased osmolarity of the blood, of the intravascular, meaning that fluid will move from the interstitial to the intravascular and the other way around. And this, we can see this in cases of hypernatremia, hyperglycemia, if BUN nitrogen is high. Okay? So this is a summary of the tissue fluid formation. Capillary permeability is important because if the capillaries are not permeable, fluids cannot go back and forth across the wall. And factors increasing capillary permeability, like inflammation or sepsis, can increase the exchange, and this might cause edema, as in sick babies. And this is how the fluids, cells, molecules can cross the capillary wall. The role of the kidney is extremely important. And we have two main concerns here about the newborn baby, which is the ability to concentrate urine, meaning to preserve fluids, and the ability to dilute urine, meaning to try to conserve electrolytes, mainly sodium. Also, the glomerular filtration rate is relatively low in the newborn baby, and the renal blood flow is relatively low in the newborn baby. And then when you compare the preterm to the term, also the preterm is different from the term baby. The preterm can concentrate urine a little bit more or less as the term, but to dilute urine, this is to concentrate. The ability to concentrate urine is more or less the same, but the ability to dilute urine in the preterm baby is less, as we are going to see. So the kidneys of the newborn baby has limited capacity to excrete or to conserve sodium. So it's both ways. The secretion and the reabsorption of sodium is limited. The range through which the newborn baby can maintain sodium, if it's high or low, is limited. And this is more evident in the preterm baby. So, there is normally diuresis in the first 24 or 48 hours, and diuresis here is both sodium and water. And the preterm babies have more limited capacity. Okay? That's why the sodium requirements for the preterm baby at some point will be higher than that for the term baby. So this is extremely important, and it will summarize what does the kidney do. The glomerulus will filtrate small solutes from the blood, and the glomerular filtration in the newborn, especially in the preterm, is limited. Then we come to the proximal tubules. They absorb certain ions, water, and nutrients, remove toxins, and adjust filtrate pH proximal. And then comes the descending loop of Henle, which allows water to pass. This is mostly for water. And the ascending loop, this is important because it controls sodium and chloride reabsorption from the infiltrate. And this explains the mechanism of some of diuretics, the loop diuretics. And then the distal tubule selectively secretes and absorbs different ions to maintain the pH, as we are going to see in the next slide. And the collecting duct reabsorbs solutes and water from the infiltrate. So the glomerulus forces small solutes out of the blood by pressure. The proximal tubules reabsorb ions, water, and nutrients. And the proximal tubules adjust pH. That's why we have what we call proximal renal tubular acidosis. How they do that? Selectively secreting ammonia into the filtrate. And then it reacts with the hydrogen to form NH4, which will help to treat acidosis. The descending loop of Henle is lined of cells, allow water. Okay. Ascending loop of Henle, sodium and chloride ions diffuse into the interstitial fluids. And then the distal tubules, it's important for potassium and hydrogen ions, are selectively secreted, while sodium and chloride and bicarb are selectively reabsorbed. That's why we can have distal renal tubular acidosis. This is how the distal tubules play a role in the acid-base balance. Collecting duct reabsorbs solutes and water from the filter. Okay. So there is, in the newborn, there is developmental immaturity of the kidney. There is also post-hemodynamic changes. And all these depends on the gestational age. And as I said, ability to concentrate urine is diminished. Ability to dilute urine is diminished in the newborn generally. And tubular reabsorption of sodium and potassium and hydrogen, and of sodium and bicarb, and secretion of potassium and hydrogen are limited. Okay. So don't think this is what I'm going to say is confusing, because you should know that the newborn baby, especially the preterm baby, is on the verge of either volume depletion or volume overload if you don't manipulate the fluids carefully. Because if you can challenge them with fluid depletion, the response is not, the compensatory mechanisms are not like in older children or adults. And the other way around, if you challenge them with overload, it's the same story. Okay? Okay. So, yes, they can have hypovolemia, hypernatremia, or the other way around. They have short loops of Henle. They have low glomerular filtration rate, low renal blood flow, and also the tonicity within the interstitium is low because the baby is not fed yet. And when the baby is fed, the intake of sodium and protein will improve this tonicity. Also, important point, the hormones are available in the newborn baby, even in the preterm, but the response is diminished. There is diminished response to antidiuretic hormone. Sodium moves with water. Sodium moves with water. And the maximum reabsorption of sodium is limited to the tubular immaturity. That's why the newborn baby kidney loses sodium more than older babies, especially the preterm ones. And this is because of reduced responsiveness to aldosterone. Aldosterone is there, but the response is diminished. Also, sodium, as we are going to see, is important for growth. It's not only for the maintaining blood pressure, body fluids, also for growth of the baby. A newborn baby who is hyponatremic will not grow normally as the one who has normal sodium concentration. This affects the brain and the organs, and this is mediated through the sodium hydrogen antiporter, and this is the answer for the one of the questions. However, the term infant is well adapted to the naturally low sodium diet provided by human milk, unlike the preterm baby. Okay? And this is how we know that sodium is an extracellular element and potassium is an intracellular. And to go back and forth, there should be a pump requiring energy called sodium-potassium pump. Bicarbonate also is extremely important, and we talked about which part of the kidney will reabsorb the bicarbonate, and it is important in the acid-base balance regulation. And it is the second most abundant anion in the blood. And usually we know this equation, it comes from CO2 And this happens in the cells, and the lung will do the reverse. Potassium is extremely important also because it's an intracellular an ion, and it's mostly excreted in the stool, in the GI, with 15% only excreted in urine. And newborn baby, especially the preterm one, is liable to hyperkalemia of the newborn, and it is because of a movement of potassium from the intracellular to the extracellular compartment. And it moves through the sodium-potassium ATPase pump. And there is low excretion of potassium, so hyperkalemia, especially in the preterm baby, is very common. And this is because of decreased responsiveness of the kidney to the aldosterone, and because of the lower GFR. Okay. So potassium regulation is regulated by balance between intake and output, mostly lost in the GI. Kidney plays only, gets rid of only 15% of the potassium. Serum potassium regulation is achieved at the age of 2 months. And what happens in the newborn is that potassium transfers from the intracellular to the extracellular space, and it's affected by many factors, including insulin, epinephrine, and that's why we use insulin in the treatment of hyperkalemia. And acidosis moves the potassium from intracellular to the extracellular compartment, irrespective of the renal potassium handling, which is not as much as in the sodium and in the chloride. Chloride moves with the sodium. It's mainly extracellular. And chloride is a major contributor to the osmotic pressure gradient and plays an important role in proper hydration, and is affected by acidosis and alkalosis, as we are going to see. Glomerular filtration rate is low, especially in the preterm baby. And it's measured by the creatinine, which is in the first 24 hours is a reflection of the maternal creatinine. And after that, it's a representative of the baby. And each age has each value of creatinine. The lungs play an important role in the insensible water loss. And it varies between 1/3 to 1/2 of the total insensible water loss. And this is important when you do mechanical ventilation, you have, or CPAP, or nasal cannula, you have to humidify the air or oxygen you are giving. The skin is an important part in the insensible water loss, especially in preterm baby, and the amount lost through the skin varies depending on the post-natal age, especially in the preterm baby, because with time, the skin will become more mature and will lose less fluids than previous. One of the important issues is the radiant warmers, which increase the insensible water loss, and also the phototherapy devices, but there is some devices now that can prevent this water loss, like the LED phototherapy. And the GI, it's the source of loss of fluids, of all other electrolytes, especially potassium. So there is loss of water, electrolytes, mostly potassium, and the sodium loss depends on the gestational age also. And the fecal potassium loss is not dependent on the gestational age. Okay. Also, the GI, through the GI, the baby can lose fluids if there is gastric aspiration, and this is the constituents of the gastric aspirate, or if there is decompression, or there is vomiting and loss of small bowel fluids. And comes the hormonal control, and the renin-angiotensin system is the most important one. It's manufactured in the kidney. There is, sorry, the kidney secretes renin, and the liver will secrete angiotensinogen. Renin will convert angiotensinogen into angiotensinogen 1, and then the lung, through the angiotensin converting enzyme, will convert the 1 into 2, and the angiotensinogen 2 will act on the blood vessels, causing widespread vasoconstriction, and will stimulate aldosterone secretion, which will help reabsorb sodium and secrete potassium. And at the same time, antidiuretic hormone works to preserve water, as we mentioned, from the collecting duct, will be reabsorbed. So aldosterone is secreted based on the angiotensinogen 2, and also the stimulus is hypovolemia or hyponatremia, and it increases sodium and lowers potassium. And there is a feedback mechanism between sodium, potassium, and aldosterone secretion. Atrial natriuretic peptide is secreted if there is high pressure in the right atrium, like in PPHN, and it causes natriuresis, loss of sodium in the by the kidney. And then comes the arginine vasopressin, which is the antidiuretic hormone, which is extremely important to conserve water. And the stimulus is either increase plasma osmolality or decrease circulating blood volume. So it maintains the blood volume constant. It makes the urine output less. And it could also be secreted by other stimuli like pain, hypoglycemia, IVH, or drugs. Autonomic nervous system is sympathetic, and it regulates the blood flow, the renal blood flow. It's stimulated by renin and by other stimuli. Fetal physiology, which will help us to understand what is the behavior of the preterm infant. And the fetal physiology, the baby is totally dependent on the mother. And the fluid homeostasis runs between the baby, the placenta, the fetal kidney, and the amniotic fluid. And the kidney starts to work at the age of 8 weeks. And by the age of 23 weeks, the kidney can sustain an extrauterine life. Definitely, the renal blood flow is low and increases with age. Also, the glomerular filtration rate is low. The length of the tubules is short, and the compartments of the fluids, as we mentioned, are different. 90% of the fetus at some age is water, and the more the baby becomes mature, loses more of the total water, which is mostly extra vascular. Okay. And I believe I have to stop at this point because this was a very, very heavy dose of numbers and factors. And as you see, I tried to summarize and brief it. If I mention every and each word in the topic, it will take me hours and hours. So next time we'll continue by talking about what are the immediate neonatal changes in fluid and electrolytes in term and in preterm babies. And then we'll talk about the requirements, the different disorders that affect fluid and electrolytes and how we can manage them. So I'm going to stop at this point and need to hear questions if you have any questions. Do you have any questions? Could you answer some of the questions of the MCQs that I gave to you based on this part of physiology? Okay. Dr. Ahmed, are you with us today? Dr. Ahmed? Dr. Marwa?
دكتور أنا مع حضرتك يا دكتور.
Dr. Marwa, are you with us?
أيوة يا دكتور مع
So,
حضرتك.
do you think it's a good idea to stop at this point, or you want me to do some like what are these immediate neonatal changes?
هو
heavy
تمام،
dose.
أنا شايفة إن هو يبقى بارتيشن يبقى أحسن يعني عشان
Yes. Okay.
خصوصا ممكن كمان الناس حتى تراجع الجزء دوت تاني
أيوة.
قبل المحاضرة الجاية بإذن الله.
خلاص. I will stop at this slide. Immediate neonatal changes in fluid and electrolytes in the early postpartum days. And just a reminder, what we discussed was we discussed the physiology, the compartments in the fetus, in the newborn, term and preterm, and the homeostasis. What are the regulatory factors, organs, hormones, structures, laws affecting tissue fluid formation? And we talked about the kidney, especially sodium, bicarb, potassium, and chloride. How does the kidney deal with those electrolytes, especially in the term baby, especially in the preterm baby, and why the kidney of the newborn baby, the preterm baby, is different, and it manages fluids and electrolytes differently. And brief idea about the lung, skin, the GI, the lymphatics, and the hormones, mostly the renin-angiotensin system, and then aldosterone and erythroid natriuretic peptide, and the antidiuretic hormone, the autonomic nervous system, capillary permeability, and we refer to the fetal physiology, maturation of the lung, when the lung maturation of the kidney. An important issue is the relation between the fluid and electrolyte homeostasis in the newborn, in the fetus, and polyhydramnios and oligohydramnios. Extremely important. Because if there is polyhydramnios, this means something wrong. There is oligohydramnios, a totally different pathology. And it helps us to understand what does the preterm baby behave. And we are going to stop at this point. Okay. So inshallah, next Saturday, if you don't mind, we'll continue. And I know it's a very tough, it's very hard topic. You have to concentrate and focus. many numbers, many issues that might seem contradictory. So please revise the parts that we discussed, prepare questions that we can discuss before starting next time. And next time also, before we discuss the topic, I'm going to show you 4 cases, and then we will be back again to the presentation. Thank you very much. And yes,
دكتور في بس بيسألوا على حلول الأسئلة إن شاء الله. هل حضرتك
حلول
ممكن
الأسئلة هتبقى whenever we done, after we finish everything.
تمام
After we finish,
يبقى بعد ما
we'll
نخلص
go back
كله.
to the questions. And I believe if you focus and concentrate, you will have the correct answer on your own.
تمام
We answered 2 of them, I believe, about the contraction of the extracellular fluid in the preterm, about the sodium potassium antiporter in the role of the sodium in the growth of the preterm baby. So at least 2 out of 10 we answered them, I'm sure. So
تمام يا
inshallah,
دكتور.
we meet next Saturday. I hope this was easy. This was not hard to understand. I made it very, very brief, but there is a lot of details. There is a lot of details, but this is the brief version of my talk. And if you know, I omitted like more than 30 or 40 slides to make it more and more brief and avoid repetition. See you next Saturday, inshallah. Assalamu alaikum.
عليكم السلام.
وعليكم السلام يا دكتور، شكرا جزيلا.
مع السلامة.
مع السلامة.